Now, if we look at the glomerulus, we have this mesh of capillaries, very fine capillaries, and you're going to have the glomerular basement membrane. Let's see if I can show it. You know that this is particularly working, but if you look at the electron microscopy in the top, you have the GBM, which is the glomerular membrane, glomerular basement membrane, and the cap is the capillary, and then you have the podocytes, these processes that are going to be around the glomerular basement membrane, and you're going to have the pores, and through the pores is going to be the filtration to the Bowman capsule. Now, GFR is the multiplication between the plasma flow and the filtrate fraction. And there are some things that actually can increase the GFR. The plasma flow can be increased by anemic states to the increased cardiac output. And also when you have nephron loss, you can have dilation of the afferent arteriole, and this is related to prostaglandin effect. On the other hand, you can have increase in the filtrate fraction, and that will put increased glomerular pressure because there's going to be dilation of the afferent arteriole, increase in the blood perfusion of the glomerulus, and finally, another mechanism for the increase in filtration rate, filter fraction, is going to be mediated by angiotensin II, and will be the vasoconstriction of the efferent arteriole. Now, once the filtrate is already in the Bowman capsule, it's going to go to the proximal tubule, all the tubular system, and there's going to be an increase in reabsorption to the proximal tubules of different solids, sodium, chloride, water, and you remember all this system with tubules is surrounded by the vasa recta. So is anything that will cause damage to the vasa recta also is going to impact the tubules. And the function of the tubules is not going to be optimal. Now, what happened in sickle cell? Well, one of the issues that happened is the loss of the vasa recta. On the left, you see that the vasa recta are intact, all these lines. However, if you compare with the patient with sickle cell disease, all of this is practically gone. So it's a lot of damage that the patient endured. This is from Saborio and Scheinman, published some years ago, looking at the module of the macrovascular obstruction that happened in the pathogenesis of sickle cell nephropathy. So first you have ischemia, you have the loss of vasa recta, as I mentioned earlier, and also you have some degree of inflammation. Now, if we look at the setting of just ischemia, possibility of bleeding, you have the papillary necrosis, patient will have hematuria, that happens sometimes in patients with sickle cell disease. On the other hand, you have the loss of vasa recta, and so you have tubular damage with hypostenuria, which is universal in patients with sickle cell disease. You have polyuria, the enuresis, and the problem with dehydration. That's why they have to be very well hydrated. And in the center, we have more the topic that we're talking today. So you have specific glomerular damage, mediated through the prostaglandins. You have an increase in the GFR, and the patients will have hypertrophy of the glomerulus that will cause proteinuria because increased glomerular pressure will lead to FSGS and lately to end-stage renal disease. Now, sickle cell is a hemolytic anemia, so there is a component of hemolysis. How much hemolysis play a role in nephropathy? And as the hemoglobin, basically the red cells break down, you have free plasma hemoglobin. The nitric oxide is going to trap this free hemoglobin, And by decreasing in the nitric oxide, you're going to have vasoconstriction. On the other hand, free heme also is damage to the glomerulus. The iron could be toxic, they're free radicals. And as a matter of breakdown of the heme, you have increasing heme oxygenase 1, and that will cause vasodilation, and that will lead to hyperfiltration. So there are multiple factors that will play a role also in the pathogenesis of a nephropathy. If we look at the problems with tubular function, there are many that have been described. There are some that will affect the proximal tubules, and some will affect the distal tubules. In the proximal tubules, you have increasing the reabsorption of phosphorus and beta-2 microglobulin. Very importantly for us, there's going to be increasing secretion of creatinine, and that's why the creatinine is so low in patients with sickle cell, and not very reflective of the kidney damage. On the other hand, in the distal tubules, dysfunction, you have impairment of the free water reabsorption and the urine concentration, and inability to maintain hydrogen-ion gradient with the distal renal tubular acidosis, and also problem with electrochemical gradient, leading to hyperkalemia. The problem is more with the concentration defect, but it does not affect the diluting effect. And some of it is because there are superficial loops of Henle in the cortex that are preserved, that have different system of capillaries and will be protected. So we don't have so much problem with the dilution. Now, we know that sickle cell is a problem with hyperfiltration. This is not the only problem. This is not the only cause of hyperfiltration. There are multiple causes. One of them is diabetes, and also a focus on mental glomerulosclerosis from other causes. But for fact, there is hyperfiltration in adults with sickle cell anemia. And here you have a table where different authors have compared the GFR of patients with sickle cell anemia with controls by the gold standard method of inulin. There was one done also with DHEA. And as you can see, for instance, the first one by Hatch, you have in the patient with sickle cell anemia 146, this is adult data, and you have in the control 117. So clearly, there is an increase in GFR due to the nephron loss compensatory mechanism. These have been also studied in mice. There is sickle cell mice, different strains of mice. And in here you can see in the first panel that in black, the mice with sickle cell will have increasing GFR compared to the wild type mice. And under experimental conditions where the renal artery is clamped, the injury that the animals endure is much more dramatic, and you will have a very much decline in the GFR, probably because these kidneys are already compromised with nephron loss. Now, how do we make the diagnosis of sickle cell nephropathy? Well, the first sign is albuminuria. This is key for the glomerular injury. And albuminuria is defined as a urine albumin over creatinine ratio of 30 milligrams per grams of creatinine or higher. Now, we know that there are divisions, like microalbuminuria is going to be 30 to 300. Over 300 is going to be macroalbuminuria, or also we call it proteinuria. Nephrotic range proteinuria usually is over 1 gram. But all of this is related to hyperfiltration and to changes in the glomerular filtration per selectivity of the glomerular basement membrane. Just to refresh memory here in terms of the different stages of chronic kidney disease, the first stage is defined by albuminuria. So just a matter of having albuminuria, that's just important for us when we are screening the patients, because that will place the patients on the first stage. After that, you're going to be having decrease in the GFR. up to the end-stage renal disease, which is stage 5, which is less than 15 millimeters per minute of meter square. It's important to realize that not only you say this patient has sickle cell, this patient has albuminuria, the patient has sickle cell nephropathy, it could be something else. So it's important when you are faced with a patient with sickle cell who has albuminuria that there will be some workup done. And some of the differential diagnoses will be lupus nephritis, hepatitis C, especially if the patient has been transfused, HIV, and other genetic factors could contribute. There are increased problems in patients with, from African descent. There's most likely chronic kidney disease. There could be some inheritance of some genetic predisposing factors. So all of that could play a role into the patient problem. In terms of the workup for proteinuria, it's important to look for lupus nephritis, doing some ANA, double-stranded DNA, measuring complement levels, also looking at serology, especially HIV, hepatitis, parvovirus. If the patient is adult, looking for myeloma screening. Very important to get a renal ultrasound and also to consider kidney biopsy, just to make sure that there is no other etiology contributing to the patient's problem. There are several findings in renal biopsy. Some of the very universal ones is the glomerular hypertrophy, which I mentioned earlier. And also the position of hemocysteine granules, because it is hemolytic anemia. Heme is going to be deposited in the kidney, especially in the cortex, and also in the tubules within the cortex. There are 4 different pathologies that have been described. The most common is the focal segmental glomerulosclerosis. And the very early one is the one that I have mentioned with glomerular hypertrophy, enlarged glomeruli, and also dilated capillaries. This is from an expert panel in sickle cell disease. These are recommendations from that expert panel. This is actually not published yet. This was a draft. This panel looked at many different aspects of disease in sickle cell. One of them was the kidney. And so the recommendation from this panel was that at the beginning at age 1, screen all people with sickle cell disease for proteinuria. Now, the panel actually recommended urine dipsticks. And of course, that's very simple. In my practice, I generally order the albumin and creatinine, and also protein. But at the minimum, a urine dipstick. And when negative, repeat every year. Now, if the albuminuria is found, the recommendation will be to order a 24-hour urine, to refer to a nephrologist, and to begin an ACE inhibitor. Also, the recommendation is to screen for hypertension every year. If the blood pressure is above 140/90, screen for renal disease, and initiate lifestyle modification or medication to lower blood pressure. Now, there is another recommendation which is less strong, and is because this patient will have lower blood pressure than usual, even if they have a blood pressure over 120, over 80. Also, you should be thinking about kidney disease and screening them. But the recommendation is less strong. And in the setting of an increase in creatinine in children over 0.7 and in adults over 1, they certainly recommend to monitor renal function and to avoid nephrotoxic drugs and imaging agents. I want to present briefly some of the data that I have been working on over a few years. And the first thing that I did was to screen the patients. So we published this. There was initial screening of 120 children. Later on, it was extended to publication for 165. But all the children were screened with urine random samples, not specific time of day. It was not the first morning urine, but generally it was in the morning. And I found that about 16% of the children have albuminuria, mean of 80. And it was pretty much even between the SS and the SC. Importantly, children over 10 years of age have higher incidence of albuminuria compared to younger children. And that goes with the recommendation of beginning screening after 10 years. Even though you occasionally have a child 4 years of age, 5 years of age, who can have albuminuria, but generally speaking, 10 years and above is where the prevalence increases. And it is associated with history of acute chest syndrome, probably related to hypoxia, and also patients who have the lower hemoglobin as well. I found that the chronic transfusions beginning early, actually at a mean age of 7 years, compared to older and a mean age of 12 years, there was decrease in the chance of having albuminuria. So transfusions at early age seem to be protective against problems with the kidney. I also look at the use of serum cystatin C. As I mentioned earlier, serum creatinine is not very good to measure renal function because of increased tubular secretion. So alternative was serum cystatin C. This is a low molecular weight protein that it will be filtered. The cutoff for filtration in protein is 68,000. And so this is very easily filtered through the glomerulus. This is an inhibitor of cysteine proteases. It is produced by all cells, filtered, and not secreted by the kidney. So it's ideal to use for renal function. And the normal is between 0.55 and 1. As you can see here on this table, if you look at the serum creatinine, and this is looking at children who had normal albumin in the urine, have microalbuminuria or macroalbuminuria. If you see in the third row, you see that really there's not much difference in the serum creatinine between the different problems. So it was 0.55, the mean in the normal albumin excretion. However, it was 0.7, although, listen, 0.7 was not a very good number, so maybe that's something to be considered, but it was not statistically significant. However, in serum cystatin C measures, there was a statistically significant difference between the children who had normal albumin in the urine and those who have higher amounts. So it seems to be better in terms of being predictive. Now, there are some factors that actually can change, can modify the serum cystatin C, and there is data that was published in 2009 from different cohorts, the MDRD, the ASK, that was African Americans with hypertension, kidney disease, nephrotest cohort. Actually, there could be some modification. If you're black or you're female, they could be lower. This is mainly adult data. I haven't seen a publication of differences in the range, so I just mentioned that to you so you know there could be some fluctuation. But certainly thyroid function, if you have hyperthyroidism, that can increase the serum cystatin C. Hypothyroidism can decrease, and the use of oral corticosteroids also can increase the cystatin C. Now, all patients with albuminuria will not have progression. I mean, we say this is stage 1, but the important thing would be, are they going to progress or not? So I followed patients for about 2 years, and I found that 10% of the patients actually have progressive disease. And that was associated with worse anemia and hemolysis. And certainly those with higher amounts of protein in the urine were the ones associated with decreased GFR. there were a very small number of patients that actually I treated in that group. There were maybe 8 patients that had proteinuria were the ones that I treated with ACE inhibitor or hydroxyurea. And actually there was a 25% among the ones that I treated that have progressive disease. And 75% that have either stabilization or improvement in the protein over that period of time. There are some factors that could contribute to progression, and I think that's very important. It's very important not only to screen the patients, but to know, to predict which patient may progress. Unfortunately, right now, nowadays, it's not too clear. So I think that's a very important area for research. Some of these factors could be environmental, such as exposure to opioids, and exposure to NSAIDs, and some of them are genetic factors. For instance, haplotype has been described as having higher incidence of nephropathy, and hemoglobin F is protective. And in the CS-SED cohort, those who have hemoglobin F over 20% did not have renal failure. So that's an important number to think about. And another consideration is those who have alpha globin deletion are more protective against nephropathy. And there are some other genes, as I mentioned earlier, that could be related to CKD. So if you have sickle cell and you also inherited those genes, probably you are more prone to have nephropathy. The data for the NSAIDs is old, it's from 1988. This was a study by Allen, and they look at 19 subjects with sickle cell and A controls, and they compare the GFR and the renal plasma flow between the controls and the SS, and it was certainly higher in SS, both of them. And the indomethacin and the sulindac lower GFR in the patient with sickle cell more than in the controls. And so the conclusion from that study was that this supernormal GFR was prostaglandin mediated, since the NSAIDs will block prostaglandins. Another interesting data is morphine and how morphine will affect the kidney. Of course, all these patients are going to have pain. They're going to be getting hydromorphone or morphine. And this is animal data, which is quite interesting to me. And these were mice that were treated with either saline or morphine. But as you can see, actually, the morphine was quite high for the mice, was 75 milligrams. But nonetheless, I think it's very interesting data. And they collected the urine, and they killed the mice and harvested the kidneys. And you can see here in this panel is that the mice that were treated with morphine, the amount of albumin and albumin over creatinine ratio was actually higher than the ones that were treated with saline alone. So morphine certainly contributed to the albuminuria. They also look at the expression of synaptopodin. This is a molecular marker for podocyte integrity. And they look at slit diaphragm constituting molecules, nephrine, podosine, CD2 associated protein. And these are protective or markers of podocyte integrity. And if you can see in the upper panel, those who were treated with morphine have less amount of these protective molecules, reflecting that there was damage to the podocytes with the morphine. And they actually found that these were related to receptors for the opioid mu and the kappa receptors in the podocytes. So I think that was quite interesting. And if you can see in the lower panel, this is electron microscopy, it showed in the left that the podocytes for those mice who were treated with saline were very long. However, the ones for the mice who were treated with morphine, they're all fused. So certainly there was damage to the podocytes, and consequently there was leakage of the proteins. Now, we want to prevent nephropathy. That's what we want. We don't want necessarily, when they are so bad, to go for renal failure. No, we want to prevent. So the question is, do we have right now any means to prevent this? And the question, of course, comes about hydroxyurea. Hydroxyurea is the only medication we have right now to treat sickle cell. It does increase hemoglobin F. We know hemoglobin F is protective, not only to the kidney, but to many other parts. And also there are other mechanisms of protection. In the multi-center study of hydroxyurea, MSH, it was published 3 years ago. You can see in yellow renal disease, the patients who had longer treatment with hydroxyurea have less number of cases of death related to renal disease. 0.3 in the ones over 15 years of age, compared to 2.8 those who were treated with hydroxyurea or were treated for less than 5 years. This is adult data, but it seems to reflect the importance of treatment with hydroxyurea. There was another publication this year. It's a cross-sectional study of 149 adults, and they found that the prevalence of albuminuria was much lower in the patients treated with hydroxyurea compared to the ones who were not, and actually was less than 1/3 likely to exhibit hydroxyurea when they were treated with exhibit albuminuria when they were treated with hydroxyurea. So I and others participated in the Baby Hug trial. This was is because we're still following the children, a multi-center, double-blind, randomized, placebo-controlled trial of almost 200 infants with sickle cell hemoglobin SS. There were infants at ages 9 and 18 months at presentation. And the primary endpoint of the study was to evaluate whether hydroxyurea at a fixed dose of 20 milligrams per kilo per day preserves spleen and kidney function. This was a study flow. All children were screened. Baseline evaluations included liver and spleen scan and including GFR by DTPA, where a single injection was given, single dose, and samples were measured 1, 2, and 4 hours. This was plasma samples. And they were followed with a number of different studies. And GFR was repeated with DTPA at 2 years. This data is the urinary concentration after overnight water deprivation at a year of age. As you can see here, the urine osmolality was quite low. This is baseline data. If you water deprive for 12 hours, you will expect about 800 or so, mean 800. And they were about 400. So at 1 year of age, they already have problem with urine concentration. And they were hyposmolar, meaning less than 280. About a fifth of them were already hyposmolar. And only about a third, maybe a quarter of them, have osmolalities in the urine over 500, which could be considered significant urinary concentration. This data is for the renal parameters at baseline. So the serum creatinine was quite low, about 0.2. Cystatin C was much higher. Usually cystatin C is higher than creatinine. And different ways that we calculate the GFR. But the gold standard that we used was the DTPA. So it was about 125 by DTPA, the GFR, at baseline, a year of age. So it was considered to be hyperfiltration already. The data at 3 years of age, it's presented here. So this is 2 years of intervention. And in bold, we see what we consider to be different. Now, the study failed to prove that actually the DTPA GFR was different. We were expecting to see that actually hydroxyurea will decrease hyperfiltration. And so we were expecting to see differences. Unfortunately, that did not happen in the study. Now, could it be that the dose was fixed, was only 20? I don't know. But interestingly, it proved that the urine osmolality was different. So they were able to concentrate better, the children who were on hydroxyurea. And the kidneys have a lower volume, a smaller volume, and that was measured by ultrasound. A study from St. Jude actually showed that hydroxyurea at maximum tolerated dose for 3 years did decrease the GFR. It went from 167 to 145. And this decrease in GFR was associated with higher hemoglobin F and lower LDL.